I want to welcome you all to BayCare Presents. This month, we have Megan Taggett here, and she's going to be talking about the understanding and the idea of genetic counseling when it comes to certain health issues. And this is a topic that I have been getting to know more about over the last year. And I am going to just turn it over to her because it is fascinating information. And I think it's something that if it's not for our own lives, it might be for someone that we have around us. So welcome, Megan, and it's all up to you now.
All right, thank you so much. I appreciate the introduction. Again, my name is Megan Taggett. I'm one of the three current genetic counselors at BayCare. Our program is currently called the BayCare Cancer Genetics Program. So most of the patients that we do service either have a personal history of cancer, family history of cancer, or potentially both. So that's typically what we're doing at BayCare, but we are also expanding into other avenues shortly. So today I'll be talking about a topic very near and dear to my heart. I'll be talking about genetic counseling for gynecological cancer awareness, prevention, early detection, etc. So today I'll be covering various topics, starting with who are genetic counselors like myself, what do we do, what is gynecological cancer specifically, risk factors, early signs for those different types of gynecological cancers. How do we detect gynecological cancers? What types of screening options do we currently have available? And who is often receiving those screening options and when? And then, of course, transitioning into what are genes, DNA, and hereditary cancer. So how can cancer pass through families? Most common examples of hereditary gynecological cancer will be reviewed as well. And lastly, how can this genetic information lead to better outcomes for individuals? So first, starting off with who we are as genetic counselors. So starting with our educational background, we typically hold a master's degree. That master's degree is on average about 2 years of time, where we study, advanced genetics, biology, and counseling techniques. So we are both a hard science field, but also soft science and psychosocial techniques as well. We do clinical training. We are cross-trained during school in various subspecialties, including hereditary cancer. But we also have training in prenatal, pediatrics, adult genetics, sometimes even cardiovascular, neurology. We can also rotate during school in various other avenues other than the clinic. We can see what it's like to work in industry for genetic testing companies, in public policy for insurance companies. There's lots of different career avenues for genetic counselors, but we are primarily trained in the clinic seeing patients. We are certified, so in order to practice, we must be certified by the American Board of Genetic Counseling, or the ABGC. And then depending on the state, I believe over 50% of the United States currently require licensure for genetic counselors. And an example of that is Florida. So Florida does require licensure and certification for us to provide our services to patients. And what do we do in general? Just speaking generally, as I mentioned, we have many subspecialties, but speaking generally, we are experts in explaining genetic conditions, helping you understand what a genetic condition means, how it runs in a family, and how that might impact your health. We interpret genetic testing results. So if you've had genetic testing either prior to coming into a genetic counseling office and we're there to interpret them, or if we order the genetic testing and then interpret them after, we discuss what that result means and how that impacts your health, what health conditions you might be at a higher risk for or have. We provide support and guidance. So we offer emotional support, help you make informed decisions about testing, treatments, and prevention. We provide personalized advice, help you understand what conditions you might be at risk for or have, and also what steps to take to improve your health. And then we work with your doctors as well. So we don't only provide the genetics education to our patients, but we also provide that same or similar education to the provider or the physician who may have referred you to receive our services. We're considered the experts at this type of testing, therefore we can't expect every single type of physician to know the things that we know, the services that we provide, hence why we exist. Therefore, we do provide physicians with that education too of how to manage a patient's care after the results do come back. And then transitioning over into what is gynecological cancer. So putting a hard definition on this for the presentation moving forward. Gynecological cancer refers to cancers that affect a woman's reproductive organs. These cancers occur in different parts of the reproductive system, including the ovaries, the fallopian tubes, the uterus, the cervix, the vulva, and the vagina. Starting with ovarian and fallopian tube cancer, the reason why I talk about these two together is they are often in healthcare and cancer care referred to as either similar or the same types of cancers, treated very similarly, pathology very similar. There's even a lot of information out there that suggests that a lot of ovarian cancers actually start in the fallopian tubes, so quite similar. With that said, I'll kind of talk about them interchangeably. About 1 in 87 women will develop ovarian cancer in her lifetime. Over half of these women will be diagnosed over the age of 63, so average age of diagnosis is in the early to mid 60s. Early signs of ovarian cancer are varied, can also overlap with other health conditions, but in general, we might expect loss of appetite, fatigue, swelling of the abdomen, digestive issues, constipation, pelvic pain, vaginal bleeding, or frequent urination. One of the main concerns with ovarian cancer and very likely contributes to how we talk about ovarian cancer in the media with our friends, with our family as being, quite a severe type of cancer to be diagnosed with, is because about up to 80% of women do not experience noticeable symptoms in the early stages of disease. When it's, stage 1, stage 2, very likely very treatable. Therefore, this exemplifies the importance of early detection strategies for women who might be high risk. So thinking about risk, going into that further, what does make somebody considered higher risk, or what are risk factors for developing ovarian cancer? Some of them we can control, some of them we cannot control. So there are controllables and non-controllables with a lot of different types of cancer risk factors. First is age. As we get older, our risk for a lot of different types of cancers does increase, including ovarian cancer. High body weight, that is a risk factor. Nulliparity or being nulliparous essentially just means that we have not been pregnant or given birth to a child. That does increase the risk for ovarian cancer. A history of hormone replacement therapy or HRT, such as estrogen, that does increase the risk. Having a family history of ovarian cancer, particularly close relatives who have been diagnosed with ovarian cancer, such as a mother, a sibling, a child, that does increase the risk. And then we do know that approximately 20 to 25% of all ovarian cancers are caused by a single genetic mutation that can be identified with genetic testing. So the type of testing that we offer as genetic counselors. So up to 1 in 4 of these ovarian cancers are caused by a single genetic condition. In terms of ovarian cancer screening, what options are out there, benefits, limitations, what's commonly used for most women? Starting with CA-125. CA-125 stands for cancer antigen 125. It's a blood test, just blood taken from the arm, like most other blood tests that you might have experienced. Results are available very quickly. And CA-125 is a blood marker that perhaps you would go into your gynecologist, have a baseline taken, see what your CA-125 looks like normally at a baseline, and then they might track that over time, perhaps once a year or at the frequency recommended by your doctor, and see if there are any rises in that number that might be concerning. The problem with CA-125 is it's typically not used for routine screening because the levels can also be used or caused by other conditions, even benign conditions of the gynecological tract. So it very often does not necessarily mean an ovarian cancer is there. And a lot of research in high-risk genetics or high-risk cancer research for ovarian cancer is we have also found that CA-125 might not even become significantly elevated until later stages of disease, which defeats the purpose of screening. So CA-125, significant benefits and limitations, and it's often not used for routine screening. So you might not ever be offered this type of test, even if you have a family history. But if you do have a family history, it's possible that your gynecologist has brought this up to you, or perhaps you've even experienced this type of screening tool. Next is transvaginal ultrasound. So transvaginal ultrasound, you may have had it for alternative reasons than cancer screening, but it can be used for cancer screening. It's a small probe called a transducer that's inserted into the vagina. It emits a high-frequency sound waves. These waves bounce off the ovaries and surrounding structures. It creates an image, our typical understanding of ultrasound, and therefore we're able to see physically what the ovaries and surrounding structures look like. Transvaginal ultrasound can sometimes miss small tumors. That's a limitation. And sometimes benign or non-cancerous conditions can appear suspicious on the scan, causing false positives. So benefits, limitations to this screening method. Often somebody might not experience this screening method unless they have symptoms of a gynecological cancer that the physician would like to look into further. And then the gold standard that pretty much everybody has likely experienced with their physician is a pelvic exam. A pelvic exam is part of a routine gynecological checkup. If you have a gynecologist, they've done this type of exam. During this, they'll manually feel the ovaries and surrounding tissues to check for any irregularities that they might need to look into further, perhaps with a transvaginal ultrasound. Moving forward to uterine and endometrial cancer. So the womb or the body of this organ system here is the uterus, and then the lining of the uterus is the endometrium. So I'll kind of use these words interchangeably as well. 1 in 32 women will develop endometrial or uterine cancer, and the average age of diagnosis is age 60. Common signs of uterine cancer include abnormal bleeding, spotting, or brown discharge after menopause. So if you have any of those experiences in your postmenopausal, very much an indication to go ahead and book an appointment with your gynecologist. Irregular bleeding or heavy bleeding in younger women before menopause, absolutely an indication to speak with your doctor. And then generalized pelvic pain or pressure is something to pay attention to as well. And you may even have abnormal pap results. Differently than ovarian cancer, only about 10 to 20% of women do not experience noticeable symptoms in the early stages of disease. So uterine cancer is often caught at early stages as long as you go and see your doctor as soon as you experience those symptoms. With that said, uterine cancer or endometrial cancer is not all the same. There are different subtypes of uterine cancer. Some might be more likely to appear with symptoms at early stages. Some might not necessarily present with those same early symptoms. So it just depends on the subtype. It's still important to know, what your family history looks like and see the role of genetic testing, which I'll talk about later. So in terms of risk factors for endometrial cancer, quite similar to ovarian, just a couple differences. We talked about age, weight, nulliparity, hormone therapy history, but also there's a specific type of result that you can get on if your doctor ever does a biopsy of the endometrium or the lining of your uterus, maybe due to some abnormal bleeding or some symptoms. They can find something called endometrial hyperplasia, which is essentially the cells of the uterine lining or the endometrium are, mutating in ways that could be precancerous or cause an increased risk for those cells to become cancer later. So that is a risk factor that can be found on biopsy. And dissimilarly to ovarian cancer, only about 3 to 5% of all endometrial cancers are purely genetic, caused by a single genetic mutation that can be found on testing. So a lot less of a proportion, but still there. And in terms of endometrial cancer screening, as I had alluded to before, there is biopsy. So actually taking a small tissue or sample of the tissue from the endometrial lining can check for cancerous or precancerous cells. So it's a great tool to be used if you're having symptoms. So again, this can be used if you're experiencing abnormal bleeding, or if you have perhaps an ultrasound that indicates there's thickening of the endometrial lining. Thickening of the endometrial lining is a hallmark sign that there could be a cancer there or developing. We have transvaginal ultrasound, which we already talked about before, so I won't belabor that. And then we talked about pelvic exam, which is also a gold standard for what pretty much every woman is experiencing for endometrial cancer screening. Routinely, it's typically not going beyond that unless somebody has symptoms or knows that they're higher risk. And then moving to cervical cancer. So cervical cancer, it's the bottom of the uterus or top of the vagina, whatever way you would like to delineate that part of our organ system. 1 in 143 women will develop cervical cancer. Cervical cancer is diagnosed more frequently at younger ages comparatively to ovarian and endometrial. Between the ages of 35 and 44 is most common, but the average age is 50. Signs and symptoms of cervical cancer are quite diverse. We can have bleeding, longer or more frequent menstrual bleeding, bleeding after intercourse, pain during intercourse, persistent pelvic pain or back pain, pain during urination or needing to urinate more often, vaginal discharge that is heavy or has an odor, and then also perhaps weight loss as well. About 30 to 50% of women do not experience noticeable symptoms in the early stage of disease, which also shows how important screening and early detection is. Risk factors for cervical cancer do differ quite a bit from our first couple examples. HPV infection is huge. HPV stands for human papillomavirus. It's a type of virus that a lot of us are infected with at some point in our life. There are high-risk strains, there are lower-risk strains. The high-risk strains are typically what can lead to a cervical cancer or other types of cancers for men and women if that person is experiencing that persistent infection. Smoking history is an example of a risk factor, weak immune system, and family history. You'll notice I don't have a genetic component there. That's because less than 1%, very close to 0%, very likely, of cervical cancer is purely genetic. Cervical cancer screening looks a little bit different than our previous examples. The general population screening is definitely there for cervical cancer. So a lot of us have experienced pap smears. The pap test involves collecting cells from the cervix to check for abnormal changes that could lead to cervical cancer. During the pelvic exam, a healthcare provider uses a small brush or a spatula to collect cells from the cervix. Those cells are sent to the laboratory for analysis. And then we also have human papillomavirus or HPV test. The HPV test checks for the presence of high-risk HPV types. Types 16 and 18 are common examples, which can be linked to a high risk of development into cervical cancer. Again, most cervical cancers are caused by a persistent infection with high-risk HPV strains. Like a pap test, an HPV test involves collecting cells from the cervix during a pelvic exam. These cells are then tested for HPV in the lab. Right now, a lot of women, especially as we get older, I believe it's after the age of 30, a pap smear and an HPV test can be done concurrently at the same time and are often recommended to be done in that way, so that we can both understand what the pap results are, what's going on in the cervix, but also if there are any high-risk HPV strains present that might indicate a more frequent pap smear that might be needed for that person to check in over time. I believe the FDA actually just approved a self-collected HPV test. I know this because I have a family member who works in this field. So I guess you can self-collect your own HPV test now, which is quite interesting. I don't know if I'd want to, but if that's something that makes somebody more comfortable, I'm all about it. And then depending on the results of these screening tests, which are available to all, if not most women who are able to access a gynecologist, there might be a colposcopy included in the screening process if needed. And the colposcopy is a procedure where a colposcope, a special microscope with a light, is used to examine the vulva, vagina, and cervix in more detail. And then that's usually used if there's abnormal findings on visual inspection or concerns with the other screening tests. And then lastly, I'll be talking about vaginal and vulvar cancer together. So vaginal is the inside of the organ system, and then the vulva is the outside of that organ system. Although I'm talking about them together, they are vastly different in their general population frequency. So 1 in 133 women might develop a vulvar cancer, but only 1 in 100,000 women will develop a vaginal cancer. So vaginal cancer itself is very rare. For that reason, I will primarily be talking about vulvar cancer for the remainder of this topic, the next few slides. And in general, these two cancers are more likely to occur in the mid to late 60s. So vulvar cancer symptoms include itching, pain and tenderness, bleeding that isn't from menstruation, skin changes, lumps, bumps, or open sores. Risk factors include HPV infection, smoking, weak immune system, family history, age, and then similarly to the endometrial cancer, that biopsy showing that abnormal cell situation, there is also a similar situation that can occur for the vulva, where there's cells that are essentially precancerous that need to be watched further. Screening, you'll recognize a lot of these. We have a gynecological exam, we have a colposcopy if needed, and a biopsy if needed, if there's any changes that need to be looked into further. Okay, so transitioning into topics that are also very near and dear to my heart, what is hereditary cancer? And how do gynecological cancers fit into the scope of hereditary cancer? So hereditary cancer is cancer that is caused by typically a single gene mutation that is passed down from one generation to the next through DNA. On average, we typically state that 5 to 10% of most cancers are due to a hereditary cause. But like I stated, that can vary depending on the cancer type, up to 25% of ovarian being hereditary, up to about 5% of uterine cancer being hereditary, and less than 1% of cervical, vaginal, and vulvar cancer being hereditary. What is DNA? DNA stands for deoxyribonucleic acid. The DNA is the instructions that tell our bodies how to work and grow, and our DNA is contained in each cell of our body. We are born with it, generally does not change over time. How do we get our DNA? DNA is passed from one generation to the next. We inherit half of our DNA from mom and half of our DNA from dad on average. And what is hereditary gynecological cancer? If a family member has a gene mutation that increases the risk for gynecological cancer or cancers, there is typically a 50% chance that they would pass that gene mutation or that hereditary cancer cause to their biological offspring or their children. This diagram here shows a father who has 2 copies of one gene. One of his 2 copies is mutated, the other is healthy. And because we pass 50% of our DNA to each of our biological children at any given time, independently of each child, there is a 50-50 chance that they would pass either the mutated copy or the healthy copy. So that's where the 50-50 comes in for these types of hereditary cancer conditions. And quickly defining a gene. So genes are part of our DNA that have a specific job. We have tens of thousands of genes. They might encode eye color, height, metabolism, but there are a subset of our genes that are supposed to protect us against cancer. You'll notice I will refer to them as cancer genes most of the time. So with that said, what are signs that we look for as genetic counselors and that you can look for as well that gynecological cancer might be hereditary? If you've experienced gynecological cancer or if you have it in your family, what are other things that might indicate that could be genetic? For ovarian cancer, we look for family history of breast, ovarian, prostate, pancreatic, and/or melanoma cancers. We look for male breast cancer in the family. We look for family history of colorectal, endometrial, urothelial, like bladder, kidney, and other cancers. Generally, young age of diagnosis is often a factor that we take into consideration in ovarian cancer as well. In the cancer field, typically before 50 is considered young. We also look for Ashkenazi Jewish ancestry in the family. So the Ashkenazi Jewish individuals experience something called the founder effect with many different types of genetic conditions, including hereditary cancer, that causes that population to have a higher risk of having one of about 10 different hereditary cancer conditions, primarily increasing the risk for breast cancer and/or colon cancer and various others as well. And then for endometrial cancer, we look for a young age of diagnosis before 50, or a personal history of multiple cancers. So somebody who has had endometrial cancer and typically a gastrointestinal cancer like colon is a factor that we consider. Personal or family history of this endometrial cancer plus others that can group together like colon, stomach, intestinal, ovarian, etc. And then there's also a special tumor study that we actually do for everybody who has this type of cancer at BayCare, and lots of institutions may do this as well, where they can determine if a tumor is high or low risk for having the most common cause of an hereditary endometrial cancer. I'm going to talk about this condition in a minute. It's called Lynch syndrome. But the screening test that we do tells us if that tumor is high or low risk for being caused by that condition. So if a tumor is considered high risk, that's definitely an indication for genetic testing. And genetic testing, as you might know it, it's a medical test that we use to look for changes or variants in a person's genes. So in our case, it's a genetic test that looks at our cancer genes to determine if there are any problems or mutations in those cancer genes that you might have gotten from mom or dad at conception. And if you did, we're able to tell you what gene that is, what cancers are associated, how high those risks are, and what to do about that. So speaking of the most common example of hereditary ovarian cancer, so what is one of the top of mind genes or hereditary conditions that we are thinking of when we see somebody with ovarian cancer or somebody with a family history of ovarian cancer? This condition you might know is called hereditary breast and ovarian cancer syndrome, or HBOC. At least 50% of hereditary ovarian cancers are caused by HBOC, which just means that somebody has a mutation in either the BRCA1 or BRCA2 genes. You might know them as the BRCA genes, so I'll fondly refer to them as the BRCA genes now. So we have BRCA1, BRCA2. If a mutation is present in either, you have HBOC. Approximately 1 in 400 to 1 in 800 individuals in the general population in the US have a mutation in one of these genes and have HBOC. The risk is much higher if you are Ashkenazi Jewish. So this condition is an example of one that falls into that founder effect that I mentioned earlier for Ashkenazi Jews. Various cancer risks are elevated in HBOC. The female breast cancer risk is up to 72%. The male breast cancer risk is up to 7%. Ovarian cancer up to 58%. Prostate up to 61%. Pancreatic up to 10%. And the melanoma risk is elevated. It just depends if it's BRCA1 or BRCA2 for how high that risk might be. They are a little bit different. And what is an example of what would change if you have a BRCA mutation or if you have HBOC that would lead to potentially early detection of cancer, prevention of cancer, better treatment of cancer? So speaking of the ovaries as an example, if you find out you have a BRCA mutation prior to an ovarian cancer being determined or developing, you can consider a risk-reducing removal of the ovaries and fallopian tubes, but typically between the ages of 35 and 45, depending on the gene. So these organ systems can be removed preemptively to hopefully prevent an ovarian cancer from occurring. Female breast cancer risk can be mitigated by screening and also surgical options as well. So screening could include annual breast MRIs, starting at the age of 25 to 29, and then at 30, adding on a mammogram, rotating between the two every 6 months. You can also consider a risk-reducing bilateral mastectomy, so complete removal of the breast tissue bilaterally with or without reconstruction, depending on the preference of the individual. Male breast cancer risk can be mitigated by clinical breast exams or potentially mammograms, depending on the gene. Prostate cancer can be mitigated by high-risk surveillance, usually starting around 40, of course, depending on family history for all of these, but typically around 40. Digital rectal exam and a PSA blood test are often used. PSA stands for prostate screening antigen. It's a blood test. Pancreatic cancer screening might be beneficial depending on the gene, typically starting around age 50 if needed. And then annual skin exams with a dermatologist. So lots of different ways that your healthcare management would be individualized if you found out you had a BRCA mutation. And then moving to my final example, what is the most often cause of hereditary endometrial cancer? This is a condition called hereditary non-polyposis colorectal cancer syndrome, or HNPCC, quite a long name. It's also referred to as Lynch syndrome, which is what we often use just because it's shorter and longer known. Lynch syndrome is just named after the physician who discovered it, by the way. So I'll refer to it as LS or Lynch syndrome. About 1 in 279 people in the United States will have a mutation in a gene that causes Lynch syndrome. Those 5 genes are called MLH1, MSH2, MSH6, PMS2, and EpCAM. These 5 genes, although they cause the same condition, they are different from one another. Some of them are more severe in terms of lifetime cancer risk and also cause more cancers than others, while some are more mild. And generally, this increases the risk of cancers, especially in the colon and rectum. The colorectal cancer risk is elevated. The uterine or endometrial cancer risk is elevated, up to those percentages right there on the slide. Colorectal cancer risk up to about 61%, depending on the gene. Endometrial cancer up to about 57%, depending on the gene. And there also may be other cancer risks as well. Common examples of what would change for the colon. Colonoscopies typically are done every 1 to 3 years, starting between the ages of 20 and 35, depending on the gene, which is much different than the average population recommendation. So super important to know if you have this condition. Endometrial cancer risk is mitigated by uterine biopsy every 1 to 2 years, starting between the ages of 30 and 35. And also the consideration of risk-reducing hysterectomy, so removal of the uterus may be recommended. Also, the removal of the ovaries and fallopian tubes could be recommended. Timing depends on the gene. Upper endoscopy every 2 to 4 years, beginning at age 30 to 40, might be recommended depending on the gene, which is just the scope that goes down the throat to look at the upper gastrointestinal system. You might also be recommended to have other types of screenings like urinalysis or pancreatic cancer screening, depending on the gene. So in general, how can genetic information help with managing gynecological cancer risk? Essentially, what I want to get across is that the best time to learn if you have a cancer or a genetic predisposition to developing cancer, especially gynecological cancers, is before a cancer develops. So the best time to know is before cancer happens, which might be intuitive, but very important to me to emphasize. Because if we find out that you have this predisposition, we can then recommend a more individualized care plan that includes screenings that might not be routinely used in the general population. We can even prevent cancers with certain types of surgeries or medications, and that ultimately will lead to early detection, cancer prevention, and better outcomes for people with high cancer risks. So in summary, genetic counselors are specialized healthcare providers that assess for hereditary disease. We provide genetic testing, interpret results, and create care plans. Gynecological cancers include ovarian and fallopian tube cancer, uterine or endometrial cancer, cervical, vaginal, and vulvar cancer. There are risk factors, common signs and symptoms, and screenings for each of these cancers with their own benefits and limitations. Genetic testing of cancer genes can provide risk information for developing gynecological cancers and other cancers too. And having a genetic mutation in a cancer gene can lead to individualized screening and ultimately better outcomes for people. So that wraps up my presentation. Thank you guys so much for taking the time out of your day to learn more about genetic counseling, genetics, and gynecological cancers. If you are somebody who you feel you might benefit from genetic testing or a conversation with a genetic counselor about your personal or family history, I have a few options at the bottom of the slide here of how you could go about reaching out or finding out about an appointment. You can ask your doctor for a referral. We have our fax number here. You can call our office and talk with our genetic counseling assistant, Heather, about how to schedule an appointment. Or if you'd like to be seen somewhere else, or perhaps you have a residence up in a different state for the summer or the spring, then you could always visit nsgc.org and use a find a genetic counselor tool, which can help you find genetic counseling services anywhere at all in the United States. Thanks so much. I appreciate it.
Thank you, Megan. That was incredible. We will be PDFing this presentation and sending it out to you, so you will have these numbers in front of you if you are not grabbing a screenshot right now. As we mentioned, this is such an important topic, and in my own journey and my own health, we've kind of talked about this on this program for a while. I had the benefit of having the genetic testing after I was diagnosed, but it was really interesting to kind of see where my risk factors were and where it went. So I highly recommend, if you have any thoughts that you might have some hereditary issues going on, give them a call and talk to them, or talk to your primary care physician so that they can help you kind of figure out what the best next step is. But like I said, the number is right here. You can always give them a call and they will help you figure out where you need to go. We do have a couple of questions for you. So you talked about the pap smear, but there's been a change in the guidelines for the pap smear. What is your thoughts about that? And then I am thinking that, if you're at risk, you can get your pap smear yearly instead of every other year. But what is your thoughts about that?
Yeah, I've read a lot about that now if you have a normal pap smear at certain age groups, that they will now not repeat that pap smear for about 3 years, which is interesting. I get why a lot of people are uncomfortable with that situation, particularly, not having any sort of visualization on the cervix for 3 whole years. That feels like a lot. And particularly for younger women, or, in the past when the HPV test was not routinely available. So you don't even know if you have a current HPV infection or would develop one in that 3-year period. That would put you at maybe a higher risk. So I do understand why that would be uncomfortable. And if that is something that you're uncomfortable with, and I definitely recommend speaking with your gynecologist. Tell them why you're uncomfortable. Do you have a family history of cervical cancer? Do you have a history of abnormal pap smears that perhaps they're not aware of, that make you feel a little bit, higher risk for that happening? Maybe you can push for an HPV test. Maybe they can do an HPV test to make you feel more comfortable, and talk about risk factors for actually developing HPV, and how to, or, having that, being exposed to HPV, and maybe how to reduce that risk for yourself. That's the comments that I have. But in general, of course, speak with your physician about that if you're uncomfortable in it. But I do understand where that comes from.
And the other question kind of leads into what you just said. It's like asking your gynecologist about getting a pap smear and an HPV. So it's not a typical test that they give all the time. Is this something you do need to ask for to get that HPV test?
It shouldn't be anymore, because guidelines have changed recently to say that after the age of 30 that you should be getting concurrent HPV and pap smears completed, but not all clinics are developed equally. Sometimes it takes many years for physicians to implement these types of screening tools, even if they are nationally recommended. So yes, if it's not being offered to you, definitely ask your physician about how to get an HPV test. And if they're not offering that to you, ask why. Is it a problem with that particular clinic? Are they just not set up to offer that to you? Do you need to go elsewhere? Trying to dig a little bit further into why you're not getting it, even if it is recommended nationally.
I'm just scrolling through to see, for the most part, there's some questions about the actual paying for the cost of the genetic testing. We do have more people on here than just BayCare team members. This is something you do need to talk to your benefits department to see if it is covered. I think Dina actually answered something below. I think if you meet certain criteria, I know for myself, I met certain criteria, my testing was paid for, but this is going to be something that's based on your individual insurance plan, depending on what company you're with, or if you're with your spouses. So you're going to need to talk to them to figure out about the actual costs. But I do think more and more of this is being covered. Is that what you're seeing?
Absolutely. So there are national criteria that we use to compare your personal and family history, see if you meet guidelines or not. Typically, most insurance companies are using these criteria to see who gets coverage, who doesn't. So as a genetic counselor, a significant portion of our session is letting you know where you fall in that risk category. Do you meet that criteria? Are we expecting insurance coverage? And what happens if you don't meet that coverage? What is the maximum out of pocket that you would ever be responsible for? And that is typically going to be a maximum of $249. That's the self-pay price at many of these laboratories. But if you are concerned or would like to talk more about that in terms of cost, insurance coverage, et cetera, we're more than happy to cover that in our appointments that we offer. Absolutely.
Excellent. Looking for a question I know I missed. I scrolled past it. It was about, do you see a lot of cervical cancer after the age of 50? Oh, no, that wasn't. Yeah, but it's, do you see a lot of cervical cancer in the older population?
So me, myself, I don't, we often don't see patients with cervical cancer because of the fact that it's often not genetic, but in general, yes, cervical cancers can occur at older ages. Even if it's not the most common age for it to occur, it can definitely still happen. HPV is the most likely cause. HPV does not age discriminate. You can get it at any age. So definitely something to keep up your screenings as long as you and your doctor decide that it's appropriate for you.
And to reiterate, because we just did get another question coming in now about the guidelines for the pap smear after the 65. That is a guideline and not necessarily what has to be done. That I think you mentioned that you really need to have a talk with your gynecologist about what's appropriate for you, because guidelines are a big picture. Any other thoughts on that?
Yeah, absolutely. And we even talk about that with genetic testing all the time, these criteria that are being met or not being met. Sometimes these criteria are just blanket statements, just ideas of what might be appropriate for a person or not. But honestly, people who don't meet genetic testing criteria, we offer them testing all the time because sometimes people who are low risk, not meeting criteria for genetic mutations and cancer genes will still test positive. Same for cancer screening guidelines. People who don't meet that guideline can still get cancer. This cancer can still happen. So it's really important to have those more comprehensive discussions with your doctor about what's best for you compared to those guidelines.
Is there a fee for someone to just call you and ask some questions to find out if it's appropriate for them to come see you, or what does that kind of look like?
Nope. So we currently do not bill even for our appointments. So we currently do not even charge insurance or charge any sort of fee to meet with a genetic counselor at BayCare. That might not always be the case, but it has been the case and will be for the foreseeable future. So if you wanted to make an appointment, all you would have to do is get that referral, give us a call, and that phone call is completely free with us. The genetic testing, if you did it, is the part that could potentially be charged to your insurance or potentially have a fee.
All right. Well, we are at time. We thank you so much for all being here, and we hope to see you next month when we talk about heart failure. But if you do have any questions, please reach out to Megan and the team, and they will be happy to help to guide you to make sure you're getting the right information.
Absolutely. Thank you guys so much for joining. I appreciate it.